Thank you. It's always an honor to be here. And for those who were here 5 or 6 years ago when the Excellence in Pre-Hospital Injury Care EMS TBI study in the state of Arizona began, it was funded by the NIH and we started, you got to see the hopes of what EPIC could be. Today you get to see the amazing results of what EMS did in Arizona. This crowd doesn't need any being talked into how big traumatic brain injury, but just 2 snapshots. Traumatic brain injury is the #1 killer of Americans under the age of 40, #1. And if you look at the years of lost life as the outcome, not just mortality, but if you look at the years of lost life, traumatic brain injury dwarfs heart disease, stroke, and cancer combined, because those tend to be middle-aged and aged conditions, whereas TBI hits every age, as you well know. And it is increasing, interestingly enough, which is against the grain with trauma in general, but TBI at all levels. The only disclosures are, I don't have any fun disclosures. I've spent my whole life writing grants to the NIH, and so that's I don't have like any drinking party stuff or anything to disclose. I'm too busy at the U. Anyway, so here is EPIC in one slide, so that those who are not familiar with the EPIC study in the state of Arizona can see. The purpose was to implement the traumatic brain injury guidelines, which, as you'll see in a minute, the really good news is, if you've read, I think Ben Bobrow and I are the only people on the planet, other than the editor of the EMS guidelines from '07, that have actually read all 82 pages of the EMS traumatic brain injury guidelines. The beauty is those 82 pages are actually only about 3 really simple things. It's about aggressive prevention and treatment of the 3 H-bombs, which we hoped people would remember in the middle of the night in the dark in a ditch when it was raining and family members were yelling at them. The 3 H-bombs: aggressively avoid/prevent and treat hypoxia, hypotension, and if the patient receives positive pressure ventilation, prevent hyperventilation. Amazingly enough, in Arizona, what an incredible laboratory. I don't use that technically. I use that as it's amazing what Arizona's done. You probably know, since '04, we have quadrupled the neurologically intact survival from cardiac arrest in the entire state. That's never happened in that large of a jurisdiction anywhere else in the world. And that created the perfect setting for the EMS agencies to say, okay, what's next? And clearly the next obvious one was to implement the guidelines in traumatic brain injury. So the massive undertaking. I don't think Bruce Barnhart's here today, but Bruce led the master trainer effort, which trained, amazingly enough, over 600 master trainers. I'm sure there are still many in this room, and 11,000 EMS providers in the state of Arizona. Just the implementation side of EPIC is really amazing, and it is by far and away the largest EMS TBI study in history. 22,000 major traumatic brain injury patients, and 4,000 intubated. Just the intubated subgroup of EPIC dwarfs almost all the other pre-hospital TBI studies that have ever been done. So a slight unpacking of this, because it sounds so simple. The beauty is this. Most of you know the guideline-based attempt is to keep patients from being under 90 on their saturation. And the way this was done on the treatment side, meaning what we taught the agencies was, anybody who has loss of consciousness and you're concerned enough to take to the hospital, you put them on high-flow non-rebreather. We can come back to the hyperoxygenation cult in the Q&A if you want to, but forget that for the moment. Everyone who might have a TBI, basically, who's going to the hospital, high-flow non-rebreather oxygen. And the reason this is both the guidelines and EPIC have emphasized that in the first few minutes, first of all, there's no data about any harm in the first few minutes, the pre-hospital care of TBI. There's lots of data about non-hemorrhagic strokes in ICUs where people were hyperoxygenated for 3 days. But more importantly, we don't believe that in TBI you can ever hyperoxygenate a patient in the field, because what you're really doing is pre-oxygenating patients to be prepared for the next crash. And the reason why that emphasis is in the guidelines is you have, think of this, on the one hand, other studies and now EPIC has showed that independently, think about this single physiological parameter, this is almost unheard of in medicine. A single documented saturation of less than 90 in the field independently triples the likelihood of death, the final outcome. That's just unheard of. A single physiological factor in the first few minutes is just unheard of. So what you have is this incredibly well-documented, your likelihood of dying if you get hypoxic is really high, and a few dotted line theoretical concerns about hyperoxygenation. So the guidelines, I believe appropriately, and EPIC pushed hard on no. The bottom line is it's so important to not be hypoxic, and we know that you run out of oxygen, people stand on the stuff, tubes pull out. You know, that's a little different than the ICU where you hear the panpipe music in the background while you're taking the care of the patient, right? So there's no such thing as hyperoxygenation. By the way, anybody heard of the Hobbit trial? This is a crack up, because one of the things we did for teaching and emphasizing oxygenation is we said, in fact, if we could put hyperbaric chambers in the back of your ambulance or rescue vehicle, and you could actually do the critical care in the hyperbaric chamber, we would do that. And guess what's being studied now in the US in 18 different not EMS systems, but trauma centers. The Hobbit trial, which is hyperbaric oxygen early in TBI care. There's actually a bunch of European data that now makes it look like in TBI it may be that actually hyperoxygenation is good in TBI. Sorry about that apologetic, but I think I just saved 20 minutes worth of questions at the end of at the end on that. Okay, so here was the other emphasis. The other emphasis, as the guidelines do, is that there's nothing wrong with bag valve mask done right in the right setting. And so, in patients who need positive pressure ventilation, by all means start positive pressure ventilation really early. And use BVM unless they have a profoundly decreased GCS, less than 9, and unless you're a significant distance from the trauma center, or the person is aspirating or at high risk for aspiration, or obviously if you're getting into a helicopter and you're going to go for 45 minutes and you're worried and you really don't want to intubate them in the helicopter, except for those caveats, emphasis on bag valve mask, if it works adequately, great, stick with it and go to the trauma center with that. Okay, the next H-bomb, stop, prevent, avoid hypotension. So try to stay at 90 or above systolic. Significantly more on this in just a minute, but this was really aggressively, is aggressive. As you can see, this is the age 10 and above, how to treat. And in Arizona, except for some interfacility transfers, there's only crystalloids. That's all there is, so that's what it was. And that's what the guidelines say in the absence. I know others will talk about, you know, there would be no argument about treating hypotension if everybody had whole blood, but that's not an option here. So the other thing that's really interesting is if you actually read the guidelines on hypotension, it's like 9 pages that says you got to avoid hypotension, avoid hypotension, avoid hypotension, which makes sense. Because a single documented prehospital blood pressure, systolic pressure of less than 90 makes the adjusted likelihood of death, the adjusted odds ratio is 2.5. It's almost as bad as a single hypoxic event. So the whole discussion for 9 pages is avoid hypotension, and then the recommendation is treat hypotension. So notice that even the guidelines are schizophrenic. So we chose to use the 9 pages of avoid hypotension, and you'll see, interestingly enough, in the near hypotensive patients, there's evidence that people got a lot more fluid in the study. And then most of you know this is just the pediatric level, different levels for hypotension under the age of 10. I'm sure you're all familiar with. So here are the hyperventilation issues. These are the go home to mama rates, right? 10 per minute in 15 older teenagers, basically, and adults. In kids, 20 per minute. In infants, 25 per minute. Many of you know that most of the studies have already shown that when not paid attention to, on average in most EMS systems, intubated adults for any reason, intubated for any reason in the field, generally have bag rates of anywhere from, on average, 28 to 36 in the literature. The irony is that if we just slowed down to the neonatal rate in EMS, we would improve. We're just horrible about this. And so End-tidal CO2 target of 40. Just an asterisk here, the guidelines say that the range is 35 to 40. We picked 35 to 45 because hypercapnia is essentially a non-issue. Out of thousands of EPIC patients, everyone always has been, interestingly enough, when they've been bag valve masked before they're intubated, they're always hypocapnic. Which leads me to one of the really simple widgets. I think this costs $3 or $4 more dollars than the standard. There's a flow-controlled bag. It's FDA approved. By the way, we're under a public health model, so we don't randomize and we don't try out new stuff. What we did was we encouraged everybody to use a flow-controlled bag, and I want you to, let's see if I can get you to, can you hear the piston throughout? Okay. By the way, the FDA, in Europe, you can't do this, but the FDA, because they're so concerned about our safety, they gave us the murder option, which is taking off that. So I realized the first time I put this in my hand, it occurred to me, by the way this flow goes is in the typical average adult, this piston doesn't engage till you're already giving twice as much flow as you should. And look at this. So I just thought about, here, let me put it back in murder mode. I just thought about all the times where I was congratulating myself, here I am at the big trauma center, 25 years of my career. I'm the trauma captain, I've gotten the tube in, I'm doing the Lord's work. Just amazing how good we are at this, right? And so I've gotten the tube in, and I'm going to use that tube. And it's my tube. Don't anybody else mess with the tube. So what's the trauma captain doing? Okay, let's see. Do we have the lines in yet? And the whole time, inadvertently, for a good portion of my career, I was killing brain cells. I didn't mean to, but the reality is, talk a little more about this later, but everybody else at Arizona's trauma centers are still doing it. Really remarkable. We'll come back to that in a minute. So anyway, I'm going to, the other thing to do is, I love this particular ventilation rate timer because it's not just a flash. By the way, the ones that do a flash tend to make you think like, okay, flash, right? No, this is a beautiful one. This is 10 per minute, every 6 seconds, and it comes on for 1 second. So what we taught in EPIC was, in adults, 2 fingers, in peds, 1 finger. If the FDA wouldn't have been mad, we would have only used pediatric bags, because you can't kill an adult with a pediatric bag like you can with the proper bag. And notice when this comes on, what we taught was with 2 fingers, you just gently push until the light goes off and then you stop pushing. And in the typical adult, if you can see their lungs moving, you're giving too much ventilation. Next time you go look at an average adult in the ICU on a ventilator, actually, you can't do that anymore. They'll arrest you for HIPAA. But if you could, or the next time you're caring for a patient on a ventilator, average size adult, that now is on the lung protective ventilation levels, 5 per kilo, 6 per kilo, right? Notice how few of them you can see there. It looks like they're dead. You can't see the chest moving. So the reality is that old idea of, make sure you can see that chest moving. Okay, you guys got it. Hyperventilation always happens. And it's really bad, and our results seem to show that reversing it have astounding turns. So, okay, how do you stop the H-bombs? The ventilation rate timers, flow-controlled bags, 1 and 2 finger techniques. By the way, what we did was, we also believed from the beginning, you do actually want the booter, the person that is the most junior EMT on the team, should be the one with the bag. Because they're the only EMS provider, they're the only emergency care provider that will do what they're told, first of all. And the second thing is, they haven't learned that advanced is better than basic, okay? Remember how many people we saved from cardiac arrest with bicarb and isoproterenol, beryllium, saved a lot of people because advanced is better. Well, we were killing brain cells with bicarb, right? So the reality is, the beauty of this is the most important person on the team that's going to keep the advanced provider who's now congratulating themselves for getting the tube in, but would never go home and say, honey, I spent 22 minutes doing perfect ventilation. Forget about the tube. I was a perfect ventilator today. Nobody ever celebrates that. So the booter will say, okay, here's the key. Get out of my way. 40, 40. Really gentle, 2 fingers. But you know what we found after a year? We added a second person called the watcher, and their job is to hit the VEMT upside the head when they get distracted and start hyperventilating. That's how hard in the emergency setting, all emergency settings, the CT scanner at the trauma center, all emergency settings where you get one of these in people's hands, we always do it wrong unless we have adjuncts. Okay, why? Why are we so maniacal? Because no one can manually ventilate properly without ventilation adjuncts. No one, not our respiratory. When a respiratory therapist says, no, I'm not putting them on the vent yet, I want to feel the compliance. When they're feeling the compliance with their hand, they're setting the person up already for ARDS, and they're overventilating and hyperventilating. None of us are good. By the way, you know what the moonshot is for manufacturers in this arena? The moonshot is the ultralight, less than 1 pound widget that takes this, no more of these, it goes on the ET tube, and within 2 breaths it tells you the tube is in, and then it does everything right. Flow, pressure, rate, end-tidal CO2, that's the moonshot, but because the baby B in the ABC nobody cares about, nobody's doing that yet. But that's where we need to be. Okay, so why do 100% of emergency care providers, why do we all hyperventilate? Because this isn't in the DSM yet, but by the way, I'll be widely cited when this makes this into the DSM because I made this up. Dan Davis stole this from me, by the way. Inadvertent ventilatory inattentiveness. Every one of us have IVI. Every single emergency provider, because the why would we worry about, now that we've gotten the airway in, why in the world would we worry about something as trivial as ventilation? So, here are the causes of IVI. Distraction's inevitable. Our adrenaline level is higher than the patient's. Proper ventilation is remarkably gentle, far too gentle for the distracted human hand to do. And the other thing is, proper ventilation just doesn't feel right. If you actually properly manually ventilate a patient, you feel like you're killing them. You feel like they're apneic. I'm barely doing anything. So this was the snapshot we gave to EMS providers in Arizona, and the training was, if you don't have a ventilation rate timer to watch, then give your very gentle 2-fingered squeeze just for 1 second, and then ask the driver to stop the ambulance, and then take your time walking around the ambulance, and when you get back in, it'll be almost time for the next ventilation. That's how it feels to properly ventilate. By the way, if you are a trauma captain here today, let me be really careful the way I say this because it happens to all of us, but the respiratory therapist is not there to ventilate the patient. They are there to set up the ventilator, and your job is to get humans' hands off of the patient as quickly as you can and get them on the ventilator, which is the only thing that does this correctly. And it really matters, as you'll see. Okay, the cure for IVI we've talked through. So here's the study design. It was a before-after system study because in Arizona, this is in partnership with the Department of Health Services. Out of the 56 states and territories, this is the only state health department that does this kind of thing. I love the ADHS and EMS. You know, in every other state, the DHS thinks they're just regulators. But it occurred to our DHS leadership about 15 years ago that a state health department should actually improve health. Who would have ever thought? What a concept. So this partnership between the EMS agencies, the university, and the DHS allows us to do public health initiatives like this where you don't have to do, it's public health, so you don't have to do informed consent on every single thing. It's exempt, the Attorney General has determined it's exempt from HIPAA because it's a part of an official public health issue. So what we did was, we did mostly retrospective 5 years of data. The run-in period you obviously remove from the analysis because the agency has some people trained but not everybody trained yet, so you remove that run-in period. And then phase 3, and what we did was we compared phase 1 adjusted outcomes that adjust for injury severity and brain injury severity and age, all the things that impact in the model. The data was absolutely amazing. This has never happened even in most small studies, but in Arizona, thanks to the EMS providers and the amazing data from the trauma centers in the Arizona State Trauma Registry, we literally had almost a 99% linkage rate between having the EMS data in our hands linked to the trauma center outcome data. Really unheard of. We actually did enter 36,000 EMS patient care records. When I say we, I mean they, of course. And we kept sharp objects away from the data entry specialist. Can you imagine doing that many PCRs, illegible PCRs? Anyway, so let me just say this about entry criteria. We were very broad. We'll unpack this in a minute. We wanted to do moderate through critical, completely critical. Some people say unsalvageable. because nobody has ever done a large implementation of the guidelines, so nobody knows who to exclude. Nobody knows who might benefit. That had implications for our overall final finding, but this is really important. The way you got into EPIC was after the fact, when you had trauma center specific diagnoses, not by GCS of less than X. The problem with every pre-hospital study is it always has people who are intoxicated that look like TBI that sleep it off and have no TBI at all. So we don't think the 3 H-bombs are really going to alter outcome of drunkenness, right? So the problem with all previous pre-hospital studies is that you don't actually have just true TBI. That's the beauty of the trauma center's data, is every single patient met very specific anatomic brain criteria. This is our JAMA Network publication from May. I think you can still get it for free, so if you just snoop around on your usual search engine, I think you can get the JAMA surgery article if you want. So again, it's gigantic, over 15,000 in the pre-implementation group, about 6,500 in the post-implementation group. And think about this, it was a stretch to most people. If we had not already done the cardiac arrest changes in Arizona, the NIH would have never believed that a 1-hour lecture and a 1-hour lab could change practice, right? I mean, the AHRQ figured out after $86 million that the one thing they could find statistically true about back in the days when they were just starting to do laparoscopic choles, I love this. $86 million we spent our taxpayers' money to find out one thing that was statistically absolutely clear, and that's you can't change surgeon practice. And I told them if they'd have given me half that, I would have told them in advance, and they wouldn't even have to do the study. So the reality is none of us want to change. So there was by no means, it wasn't a no-brainer that anything was going to happen, right? Just because we trained 11,000. Here's what's amazing. And some of this may well be because EMS providers may be unique in healthcare in their willingness to say, oh, that makes sense, I'm going to do something differently, right? They don't have anything to protect. And so maybe they're unique in leading in this. But look at this. Sorry for those on that side, but actually, sorry for you. There's more over here. Look at this. Implementation was associated with a lower rate of intubation, even though the post-intervention group had far more severe brain injury. We don't have time to talk about it, but there are reasons to have expected that to happen. A much higher rate of BVM. Think about this. In all patients with positive pressure ventilation, right? Positive pressure ventilation is bag valve mask plus intubation plus supraglottic airway. It's a small group, but it's still, all of those are positive. All of those are active ventilation. In the positive pressure ventilation group, in the after group, it increased. The number that just got BVM went up by 40%. Practice really changed, which is astounding to me. A greater reversal of hypoxia. So think of this. In Arizona, if you were in the after group and cared for by EPIC certified agencies, if you were hypoxic at any point, the likelihood you showed up at the trauma center still hypoxic dropped by 50% in the after group. Amazing focus on trying to treat hypoxia at least. A greater likelihood of receiving a fluid bolus in hypotensive and near hypotensive patients, even if you look at the other under 110 and dropping, there was a marked increase in the likelihood that you would get a bolus. And if you got a bolus, a far greater volume. If I leave my time for any questions at the end, we may interact on the hypotensive stuff. And then a lower rate of hypocapnia in intubated patients. So in fact, the combination of training and the piston hollering back at you and so forth significantly decreased the number of patients that had documented PCO2 of less than 35 at any point in the field. So here's the overall outcome. This first one matters a lot because obviously survival to actually be admitted to inpatient status at the trauma center is very proximate to the pre-hospital care, right? So it's an intermediate outcome that likely helps you look at whether pre-hospital care changed. And amazingly enough, in the state of Arizona, across moderate, severe, and critical TBI, your likelihood of being successfully making it to inpatient status in Arizona was an adjusted rate that increased by 70%. Really remarkable. Very unlikely to be from anything major changes in the hospital because there were no apparent major changes in the hospitals at that point. The 98% of the patients in EPIC were cared for by level 1 trauma centers that have had that status for more than a decade. So it's a very mature trauma center system in the state. And survival to discharge, the odds ratio means it tipped toward the right in the whole group, but was not statistically significant. But this is important. In advance, we knew in our pre-planning for the analysis, we knew there was the possibility that only some patients would benefit. In fact, we had thought that the moderate patients were so unlikely to die that their mortality probably wouldn't change. And we believed that the incredibly critical patients had such severe primary injury that even preventing secondary brain injury wouldn't markedly change their risk of dying because the primary injury may be so severe that it drives their mortality. And so we, in advance, did, for those who are familiar with AIS scoring, this is the moderates, 1s and 2s, severe, 3s and 4s for brain injury, and 5s and 6s critical. And those who are familiar, you know the 6s are supposed to be unsurvivable, but again, we kept everybody in for the big study. And for those who don't think in forest plot, those who do think in forest plot, this is a holy cow moment. This is the severe group, which, by the way, made up 3/4 of the intervention group. So severe TBI is a gigantic part of major TBI in the state of Arizona. 3/4 of TBI patients in Arizona. And so, just so you know, so this is the unity line, and this is adjusted for all the things that impact on mortality, like brain severity, overall severity, age, et cetera, and so forth. The model scores really well. It's a very mature model. And this is absolutely amazing. The adjusted odds of surviving a severe traumatic brain injury in the aftergroup was 2. That means it doubled. The adjusted likelihood of survival doubled. And in the intubated severe subset, it tripled. Okay, and these wide things are here are if the left side of these don't touch 1, it means it is statistically significant. In fact, these are so significant, the p-value is something like 10 to the -7, but our senior biostatistician said, Dan, you can't publish that many zeros. It looks like you're showing off. Just use 3 zeros. But it is unbelievably statistically significant. Okay, EPIC for kids. It's the proverbial I could tell you, but I'd have to kill you. It's now in at a major journal that is under review. We're hoping we'll publish it. The results are embargoed, but what we will say is they are consistent with the all-age findings. This is what I'm showing you is the all-age findings, and in fact, they are really remarkable. They're stronger than the all-age findings, which is not surprising to those of you who know a lot about TBI. The plasticity in children does not surprise us. And then the pre-planned air medical analysis of looking at ground, the effect in ground and the effect in air is also under review. So the results are, I will say, at least as good as the ground group. If I had more time, I'd talk about the limitations, but this is a slide you should always spend a little time on, just as for your junior speakers. You know, have a limitation slide so everybody say, oh, that's good, they talked about limitations, but then don't talk about it. Okay, so implication number 1. Implication number 1. It's not randomized, so we didn't prove anything, but we found independent associations with biological plausibility in a pre-planned analysis. So this isn't get a bunch of patients, go back and go fishing and say, oh, the p-value is less than 0.05. Okay, so implications. Number 1, I started 5 minutes late. Does that give me 5 minutes? Okay. TBI, you guys are going to have to listen faster. Implication number 1, TBI may, some of you will get that tomorrow. Implication number 1, TBI may have a therapeutic sweet spot. So in fact, interestingly enough, there was no effect in the moderate, no apparent effect, and I'm using effect loosely there, and there was no effect in the extremely critical patients, but there was a dramatic, independent increased likelihood, adjusted likelihood of survival afterward. Number 2, this is a quantum leap in outcomes. If you just Google the last interventional study in the New England Journal of Medicine, the #1 journal in the world, where death is the outcome, you'll find studies in the New England Journal where, oh my goodness, it improved mortality by 11%. To take a major public health issue and talk about an odds ratio of 2 is essentially unheard of in medicine. And that leads to this. Why would that be? Because the neuron dies so fast with low oxygen or low flow. right? The concept, some of you are, actually, you've heard about R.A. Cowley in the literature and, on Nickelodeon, probably. But I actually knew R.A. Cowley, right? God with a little g, R.A. Cowley, and that's where the golden hour came from, right? Which for 60 years now is a conclusion in search of evidence. But in any case, think about this, there's not even a platinum 10 minutes for the neuron. The injured neuron starts to die, starts apoptosis with 4 minutes, count them, 4 minutes of low flow or low oxygenation. So, in Arizona, the first 26 minutes was on average the time from arrival at the patient until arrival at the hospital. In fact, I think this is just trauma center data. So arrival at the trauma center. So this is direct to trauma center, which was something like 75% of the cases. 26 minutes of pre-hospital care, and on average in the severe group, 6.5 days of hospitalization. Imagine something happening in the first 26 minutes of a 6.5 day total healthcare service unit, doubling survival. It's absolutely staggering. So it's remarkable what happens in the first few minutes. So probably what it does is, what happens when the neurosurgeon does flawless, perfect craniotomy and removes the hematoma and the patient's neurons are already dead? Nothing. So it's probably synergistic with subsequent specialized trauma care. But if they get dead neurons at the trauma center, it doesn't matter how good the trauma center is. So it probably, these few minutes seem to matter that much. This one is a complete blowaway. Implication number 4, the current hypotension threshold may be too low. And I say may because we haven't proven this, but we have several big multi-center trials that we're doing out of this. So I'll come over to this side. Okay, now everybody knows that the hypotension threshold is 90 because God said it was 90 about 40 years ago, and it couldn't be 94 because 94 is not cool like 90. It has to end with a death, right? It has to be one of the 10s. And so guess what happened? All the studies in hypotension TBI history, almost all, that's not true, but almost all of them took 90, and guess what they always found? No matter how big or small the study was, it's always better to be higher than 90. So 90 became the rule. Okay, so if that was true, this is really important to watch. I'll show it on both sides. This is the adjusted likelihood of dying. So it's good to be lower on this, okay? This is the adjusted likelihood of mortality across 22,000 patients. So this is a gigantic cohort, which is why the 95% confidence bands are so tight, right? Why we're so confident in this line. If we were right before, when we got to about 90, and nobody believed it was 90, they thought, well, maybe it's 88 or maybe it's 93, but it's what should happen is this should be a plateau around 90. There should be an inflection point where you do better. It's like, well, at least if you don't go really low, you're okay. That's how we've treated it, right? Low is fine, but really low you can't do. Notice you ready for this? Between 40 and 120, it's an absolutely straight line. In fact, it gets worse. Because we have so many patients, this is a complete blow. This is in the JAMA Surgery article from 2017. You can look it up if you want to. In EPIC, you ready for this? If we had had EPIC 40 years ago and said, hey, we're choosing 135, guess what? In 22,000 patients, if you use 135 as the threshold, it's better to be higher than it is to be lower. In EPIC, it doesn't matter what threshold you pick between 60 and 135, it's always better to be higher, and now it gets worse. Because EPIC has so many patients, we can treat blood pressure like a continuous variable, okay? So notice this, all the literature, because it had tiny studies, always had to have a low group and a not low group, right? You just dichotomize, because there's not enough patients. We have so many patients that we can treat it as a continuous variable across the entire spectrum. And so we can ask the question, well, what's the best blood pressure to have? And this is scary. Here it is. Okay, let this baby sink in. This, by the way, this is embargoed, so don't tell anybody you saw this, okay? So look at this. Between 0 and 135, it is statistically not different from a straight line. Maybe around 115, 120, it gets us slightly better. But you ready for this? This is basically a straight line to 135. And by the way, this is the lowest documented pre-hospital blood pressure. Not the average, the lowest pre-hospital blood pressure. There's a low adjusted mortality of, ready for this, 135 to about 180. Holy cow. And on this side is a mechanistic mirror image of this side, right? Think about this. On this side, this is what blood pressure does to the injured brain, right? Hypotension's bad for the injured brain. This side is what the dying brain does to blood pressure, right? But by the way, we'll come back to this. Why do you think we die like this when we have a bad head injury? Do you think maybe it's because teleologically the injured brain really wants to be perfused? The cardiovascular system forgets every other regulatory issue. When the neuron is starting to die, it puts as much pressure as it can into the brain to try to perfuse the neuron. We should have known how important this was just from that knowing history. So don't hear what I'm not saying. Let me say that again. Don't hear what I'm not saying. I'm not saying we should treat patients to 130. This wasn't a randomization comparing 90 to 120 or 90 to 110. Okay, so those studies are going to need to be done. But what it may mean is 90 and 135 to 180, holy cow. As a researcher, my answer is I don't know what to do with that. But as a medical director of EMS systems, I'm thinking, oh my, I don't think I like letting people drop to 90. It's a really big deal. Okay, what I am saying, yeah, that's enough. Implication, effective interventions are rarely simple and inexpensive, right? We're always looking for the unobtainium drug, right? The $1 million unobtainium drug. This is just too simple. We already know how to put in IVs. We already know how to give high flow O2. We already know how to intubate, and we should know how to ventilate correctly. It's just 3 interventions done really, really well. Let me show you one last slide, because when the moderator stands up, by the time you're a tenured full professor, you've figured out when the moderator stands up, it's a bad sign, especially when they're a trauma surgeon, because they start doing things. Let me just show you this. Distraction and loss of focus are an ever-present risk. This is staggering to me. On average, the typical agency was in the post-intervention time for 3 years. 5 years in the pre, 3 years in the post. And we didn't have control of retraining. We only had control of initial training. So now that you're bilingual and you think in forest plot, notice it's good to be to the right of the line, okay, for outcomes. This is the severe head injury group, all severe head injury. And this is splitting in half the intervention. Whoa, the intervention group, that was a good one. Yeah, that's right. Hey, I'm being preemptive. Uh-oh. Did I really do that? Okay, good, thanks. Okay, so that's right. Let me just warn you, big guy. This is staggering. Look for the first 18 months, the adjusted odds of survival improvement was almost 2.5 compared to 2 for the whole group. And after that, it was still statistically significant, which is astounding to think that 2 years later it still mattered. But notice this, it dropped to 1.7, and this is really amazing. Among head injury patients that had severe TBI in Arizona, think of this, the adjusted odds were 5. To put that in English, the adjusted likelihood of a severe intubated TBI patient in the state of Arizona went up by 400% in Arizona. It's staggering. And half of it was lost. So this is really important for every healthcare provider. And let me just make sure, whether you're EMS or whatever, if you're not paying attention to this, QIing it, if you're not looking at the tracings, if you're of end-tidal CO2, all of us forget this and do it wrong. And I think I better stop do I have time for questions? Yes. Okay. All right, sorry, I left like 19 implications out, but anyway, any questions or comments?